of the brain. So the picture that we saw before, the defect is there, and here's the actual defect. So there is a neurotransmitter which is called dopamine. Dopamine is an important neurotransmitter released at that particular part of the brain which I showed you the picture of, and it's involved with fine motor control, motor movements. Motor movement means I think to myself and I say, I'm going to lift my hand. That's called a motor movement. There are other movements which happen inside the body which are involuntary movements. You know, my intestine is working right now and my heart is beating and I just have no clue. So those are non-motor movements. So the major defect is, as you can see in the picture, healthy patient. This is kind of just a cartoon, I guess, and a visualization aid. And in the Parkinson's disease, Parkinson's patient, so the amount of the dopamine which is being released by these nerve cells decreases. So what's the physiology or the basic defect? The lack of adequate amounts of dopamine in a place which I showed you called substantia nigra, or the midbrain, which is the main defect which causes Parkinson's disease. So a couple of more pictures so that it sits in your image. Now this one, is, I want to show you three ways, three-dimensional. This is a cross-section of the brain. So again, it's basically showing you where the substantia nigra is when you dissect the brain crosswise. One more. And then this is the one which is showing you the bottom part of the brain. So that's where the substantia nigra, or the midbrain, is. So this is a picture taken from the bottom. So hopefully I've shown you all the different views so you understand where it is. Let's get out of this and go to the folder 2. Let's look at the first picture there. No, the other one. Yep, the first one. So, new technology allows you to actually trace some of the dopamine. So they have special scans, I think it's called DAT scan or something like that, which nowadays can be ordered to help you confirm the diagnosis of the Parkinson's. So the diagnosis of Parkinson's mostly is clinical-based diagnosis. You listen to the story, you examine the patient, they have the triad of 3 different things which we'll go through, and basically the neurologist is usually able to make a diagnosis. Another thing which is very important in diagnosis is how does a person respond to a particular Parkinson's medication, and that sometimes is a test itself. So those medications for Parkinson's usually do not help other diseases. So if a person has Parkinson's, he will have an immediate response to the medication, and that tells you that this person has Parkinson's, because those medications, all they have is dopamine. So if you have a lack of dopamine, you give them dopamine, all of a sudden you get a dramatic response, you confirmed your diagnosis. But nowadays, and it was really cool because they do have new technology which can help you make the diagnosis. So you can see that that's a healthy brain, and right that area where I showed you the picture of, there's a lot of activity of dopamine going on. So as I said, I think it's called DAT. It's related to the PET scan. It's a brother or sister of that, but it mainly concentrates on activity of the dopamine. So then you can see in the Parkinson's disease, this is early Parkinson's. When you're developing some symptoms, this is when they develop the symptoms, and you can see that there's a lack of activity of the dopamine in that area. You can get out of this. So what are the symptoms? What does the person present with? The first one we said was what? Tremor, pin rolling tremor. The other symptom that people usually get, loss of smell. Now that's, some of these things, they happen, but they're hard to quantify. It's hard to assess that. The patient will not come and tell you that I've lost my sense of smell. Why is this important, the loss of smell? Because what happens is, once I make a diagnosis, or I've seen people with Parkinson's and follow them for several years, they tend to lose weight. And part of the reason that they lose weight is because they lack the ability to smell the food. There are other reasons too. When they lack the ability to smell, the food just doesn't taste good. So if I was to take away your smell today, most likely the chances are that some of you will lose weight because of that. So they also get small handwriting. So people have mentioned to us that, you know, I noticed my handwriting got affected. And there is a very, very typical, yeah, I can give you those. Yeah. So there is a very, very typical way that the handwriting gets affected. So the person would say that I start off writing, so just look at these words here. You can see that's normal on the top, A, B, C. And the person who has Parkinson's, what he does is he starts writing everything smaller. So he doesn't write them the normal size. He starts shrinking it down a little. Also what he does is starts squeezing things together because he doesn't want to do longer movements. So what happens is the movements in the body, they become shorter and smaller. So the handwriting, I've actually seen somebody, I asked them to write, you have to ask them to write a long sentence, and you could do this with some of your patients. And what you're going to notice is they'll start off okay, and then as soon as they go into the sentence, it'll start becoming smaller, smaller, smaller. So that's a very typical sign of Parkinson's disease. Because there's another disease called essential tremors. And you know, it's very common, and that's the biggest question that we get asked. I have a lot of people with essential tremors, and as soon as they have essential tremor, they want to know, do they have Parkinson's? And I'll explain you the differences in those. And also I'll show you, I've got some samples of handwriting of people, Parkinson's versus the essential tremor. And remember I said a person has a tremor, resting tremor, in Parkinson's, and as soon as they start movements, the tremor actually becomes less. With the essential tremor, what happens is they have less tremor not moving, but as soon as they try to do something, like try to get a spoon and try to feed themselves, all of a sudden the tremor becomes more. So it's more of a postural tremor. It's usually not resting tremor. So that's the handwriting tip. The sleep problems, they will sometimes have excessive, they can even fall out of the beds. They will do that, because they're acting out on a dream. So in the dream, they have a movement, they do something, and they fall out of the bed. The sleep patterns also get affected, just like with dementia. In the later stages, they have reversal of sleep cycle. So they will walk around at nighttime or stay awake, and then during the daytime, they will be sleepy. Another main problem, trouble moving. So why do they have trouble moving? Because they get stiffness, muscle stiffness, or rigidity in the lower part as well as the upper part. So when they get it in the upper part, what they do is a person who would normally have a nice swing of arms when they're walking, they will have less of that. So they don't swing their arms as much. Also, the gait, or the way that they walk, it's called a shuffling gait. So instead of taking a nice stride, they just shuffle. So that's called the shuffling gait. There's another gait called magnetic gait, which happens in people with normal pressure hydrocephalus. I think in the whole Lake County, Dr. Chang has probably diagnosed the most of those people. He even I think they even wrote an article about him, my partner, Dr. Chang. He's an expert in picking those up.
I sent his email to him the other day.
He's very good. So what happens in the normal pressure hydrocephalus, you get, which is swelling in the ventricles of the brain, you get the magnetic gait. And magnetic gait, what happens is, imagine that your boots have got magnets to it, So now you're stuck to the ground. So what you do is you want to pick them up like that. So imagine the feet are stuck to the ground and you're trying to do that. So that's the normal pressure hydrocephalus gait called magnetic gait. Parkinson's has shuffling gait. So they take small steps and they kind of shuffle. Also, here she is. That's it. But the arms, but she doesn't know how to do it right because the arms are not going with it, and neither is the.
They don't go that fast.
And I know she doesn't. So I said the other muscles do get affected too. The motor muscles get affected, the motor nerves gets affected, but other nerves do get affected too, which are responsible for internal involuntary movements. And the ones which get affected most are the intestine. So most of these people, they get constipated. The constipation is a very common problem with Parkinson's. Very important for you guys to realize, because if a person comes here and you don't pay attention to it, and especially if they're taking pain medications, and the medications we use to treat Parkinson's, they also cause constipation. So you got double whammy there. So what can be the problem with that? You guys here, you will get the obstruction. You know, what do you call it? There's a word for it. Impaction. That's it. So, and then you have to send them to the ER, which we don't want. So valves, you have to pay attention to that. You know, it doesn't say it here, but the mind itself, the cognitive functions, they also get affected significantly, which includes memory. These people become more anxious, and also they have a much higher incidence of depression. Now, those are the things that usually are not obvious, you know, and they don't usually tell you about it. The obvious thing that we see is tremors. We see they're not walking right. We see there's a problem with the posture. But these are the things which happen behind the doors, which you have to be aware of, because you can make them a lot better if you're able to take care of their depression, anxiety, and help them with the memory. Masked face. So the masked face basically is when a person has an emotion, so he is happy, supposedly, but on the face, he looks angry. So the emotions inside, they're not reflected on the face. You know, we all have emotions, and we have hundreds of muscles in the face, and they usually go with our emotions. If we're angry, we're scared, whatever it is, it shows up on our face. So these people, they don't. That's why they call it a masked face, because it doesn't allow you to see their true emotions. And of course, they're not trying to do it on purpose. Stooping. So that's what she missed. There is a little stooping of the back. I'll show you a picture of that, and once you see it, it will become very obvious. Voice change. The voices become softer, so they're not able to talk in a loud voice. Now, my daughter, whenever she screws up or does something bad, she has the same thing. She can't speak up. I can't hear you. And normally she's shouting all the time. But as soon as they do something wrong, then they can't speak up. But again, these people, they will have softening of the voice. And you know, if the spouse has got a hearing problem, they will tell you, I can't hear him. He talks so, he can't talk loud enough.
Does it affect one sex more than the other?
Yes. So I've never seen a female Parkinson's patient. I don't know about you guys.
Yes. Yeah.
You have? But is there any difference? But is there a difference in the ratio?
Oh, yeah.
Yeah, big time difference. So as I said, I've never seen a female.
We just thought we just attracted.
Yes, you have more. You have more. That's why. But you're going to notice that men usually get it a lot more commonly. We can get out of this. So this was another picture with the symptoms, and I kind of wanted to, on the skin, they have increased sweating also. So that's another one. The reason I put up this slide, because the other one missed out a few things. You also can get something called blepharospasms, spasms of the eye muscle, and then the lung there. The reason you want to know that is because they are more prone to aspirations. So that is something that you guys need to pay attention to. Parkinson's patients, they are much more prone to aspiration. And I think this slide finally picks up that fact there, that they can have depression, anxiety, and all that, along with the psychological problems, along with the physical disease. We can get out of this. So here's a, yeah, that's a bad picture. I tried to get it, but I couldn't get it. So you can see the person has started writing, and he writes a little normally, but then you see as soon as they go down, the print becomes smaller and smaller. So that's a very typical, I can't think of any disease in which you would have that. So that's a real picture of a person, yeah. So the things that you see actually is the things that you know, there's got a lot of things listed down here, but the things that you actually see in a person are the tremor, the hand tremor. If you're paying a lot of attention, you may notice that you've got a reduced swing of arms. But you know, when a lot of people get older, some of these things are going to be there anyway. You know, the stooped posture, that's just very common to see. So shuffling gait is very classic, so if you see them walking. And then the other thing is where's the rigidity? So they're showing that there's back rigidity, but it's not just the back rigidity. It's rigidity in the pelvic girdle muscles, the thighs, as well as the arms. And one of the things you should do, if any one of you has a patient, next time you see them, take their hand and basically what you do is you just take the hand and flex it at the elbow. Just try to move it back and forth. And what you're going to notice is there's a typical rigidity called cog wheel rigidity. So basically what it does is it locks up, then lets go, locks up. So you're going to notice there's this locking movement as soon as you move their elbow. And that's also very, very classic for this disease. Can't think of too many other diseases which have that. So the neurologist usually will pick it up by looking at the frequency of the tremor, their walk, their face, and the cog wheel rigidity. Let's get out of this. I think we're done here. This is number 3. Now how do you treat it? Actually, before we go to treatment, let's get out of this. Look at the last, then I'll tell you about it too. So before we go to this, there's another one, sorry, another slide. This one, yeah. So the commonest mimic of Parkinson's is the essential tremor. So the essential tremor, you're going to notice, we notice a lot more people who have that compared to the Parkinson's. So one of the things about the tremor is it's a resting tremor in Parkinson's, as I said, and the essential tremor is postural. Postural meaning usually happens when they're trying to do something. Most of the common thing is when they're trying to eat the food or drink a soup at the restaurant and they can't do it. Now the Parkinson's tremor doesn't get worse with stress or anxiety or anything like that. But the postural tremor or the essential tremor actually gets affected by stress. So people will tell me when they get it, you know, the tremor is okay, but as soon as they get at the Christmas gathering or, you know, when their family's around and now they're trying to eat, they all of a sudden can't eat properly. The food kind of falls off their, they can't bring the food to their mouth. So whenever they're under stress, the tremor gets worse. And what I usually tell them to do, if they are not alcoholics, I said, have a glass of wine. And if they have 1 glass of wine or 2 glasses of wine, immediately the tremor goes away. But only for 4 hours. Or 3 or 4 hours. So either you gotta keep drinking.
Because they weren't an alcoholic before they started.
Yeah, they won't become alcoholic then. Yeah, that's a different disease. you gotta have the gene. So if a person complains that they're fine otherwise, they only have the tremor when they're at the food table in different people, the solution, just have a glass of wine. That's it, that'll cure them. So the alcohol is actually listed as one of the things which will tell the difference. So it has no effect on the Parkinson's, marked reduction in the tremors. So how do we treat the essential tremors? Usually with the beta blockers. That's one of the treatments, like propranolol. So you have to give a beta blocker which penetrates the blood-brain barrier. Not the atenolols, not the tenormins, not those ones, the propranolol. And what it does is, it's effective treatment for essential tremor, one of the effective treatments, but the other one, usually it doesn't have any major effect on that. Now, What does have effect on the Parkinson's disease is the levodopa, which is the dopamine. Now that's very effective for Parkinson's, at least in the initial stages, but it's got absolutely no effect on the essential tremor. Somebody comes with tremor, you give them levodopa, immediately goes away, you know it's not essential tremor, you know it's Parkinson's. The other one, the family history, yes. So the family history is positive half of the time in people with essential tremor, and in Parkinson's is very rare. So if you go talk to these people who have Parkinson's, usually they will tell you they don't have any family member who has it. There's a rare form of Parkinson's, which is genetical. It runs in the genes. So you have a lot of family members in that pool who will have it. And then there's another rare form of Parkinson's, which happens with the methamphetamine users. So, you know, because they cut these drugs to make methamphetamines, so sometimes they have noticed that all of a sudden these young people, they develop Parkinson's. And they trace it back to the illegal use of methamphetamines. Because those drugs, they do affect that part of the brain, and they can kill those brain cells and cause Parkinson's. So very bad.
So what about the
Speed.
There are Parkinson's that affects younger patients as well?
That's the one then.
Oh, that's the only one?
That's the one.
Michael
Yeah.
J. Fox?
That I don't know. So I don't know what he did. He does have Parkinson's, yeah, unfortunately. So what we say is that the commonest age group, the commonest age group would be above 60 to get Parkinson's, but you can get it at younger age too. It's just rare. And then those younger ones, the 30-year-olds that are getting it, it's usually from that activity.
Oh, wow.
Yeah, otherwise it's uncommon.
What about the medical marijuana?
No, it doesn't cause Parkinson's. So the question is, can you use medical marijuana for the treatment of Parkinson's? And I guess it would be listed as one of the possible treatments for it. Now, it would not treat the disease itself, but what it will do is it will treat some of the symptoms, and the one I guess that it will treat more effectively is the rigidity. See, when you have pain due to the increased muscle rigidity, because it does relax your muscles. So yes, it's probably there, you know, for muscle rigidity and all that. But then the problem with it would be that it can also cause, older you are, the more mental effects it can cause too, like hallucinations and all. And that those are very common in that disease when they have a little dementia. So they will. What's that? Yes, it is. But then again, it will most likely create these people to have more hallucinations and all that too. So I guess the only way to do it would be to try it for the muscle rigidity and see if it helps.
We used to have a guy who had really bad hair.
Yeah.
He used to sneak out.
And have it
Well, he'd dance.
Yeah.
And the thing, he turned his music on and danced. And he could dance with no problem.
So that's most likely not the medical effect of it. So I'll tell you what it is. So first of all, as we said, the tremor improves with movement, you know, if they were doing it. So most likely he gets a high from it, desire to dance, and when he starts moving, the tremor becomes less. So that's probably the explanation for that. It's not the medical benefit of marijuana to the disease itself. It's mostly on his mind. If somebody wanted to ask a question that way, you know.
Did you have a question?
Oh, I heard amphetamines. What about all the kids on like Ritalin and Adderall?
No, you see, the Ritalin, yeah. So what happens is the Ritalin is the FDA approved medication for treatment of a condition. So the way the illicit drugs are made, you know, the speed-like drugs, they modify the Ritalin. So when they are modifying them, they're creating a new chemical, which has totally different properties than the Ritalin. It still falls under the same class because it's made out of them, but they're different. So we're talking about illicitly made drugs. Now, not all of them, but there have been reported batches of the drugs which were made in a certain lab. They caused people to get Parkinson's. So it's not all over. So I guess if there is a good chemist who's making a better version of it, it's probably not going to cause that problem. But there were some bad chemists who messed up how they make it, or how they cut it, or how they do it.
Yeah,
So No, he was good.
Oh, yeah, he was a good chemist.
He was a good chemist. So not the Redland, no, it's the illicit ones which have been made out of that. So, another question, okay.
Question, doctor. Does music increase production? Because there was footage in physical therapist, home health physical therapist was treating a Parkinson's patient, and without music, he had the fascinating shuffling gait. With music, but he was swaying with it, and the shuffling gait shifted.
Yeah. So the dopamine is the one of the neurotransmitters which is very important towards happiness in a man's, woman's life, in human beings. So when people use cocaine, it actually releases dopamine. So that's the major neurotransmitter which gives people high from use of cocaine. The difference is the dopamine is not released only in this part of the brain. It's also released in other parts of the brain too. So the pleasure center, which gives you a high or a feeling of well-being, is not substantia nigra. It's the other parts of the brain. So the music has been, it's not just music, even exercise, even doing, gambling, any other activities of that kind, or when you get all of a sudden a big bonus, so you feel happy. So what happened was you released dopamine in the particular parts of the brain which give you the happiness. So what would happen is the person who's got, working with the physical therapist, the music is releasing his dopamine, not in this area, in the other areas of the brain. So it's making him happy, and he goes with it. Of course, he has to like the music too, most likely, to get that. If you don't like the music, you're not going to get the release. So with that, it's the same thing as this person who was smoking out there. So he wants to move now. So once he moves, the tremor will improve, because the tremor is mostly a resting problem, less of a problem when you actually start moving. But again, these are case studies, most likely. Okay, so one other thing on the table was that the Parkinson's, age 60, most of the time is common age. Essential tremor has been known to happen even as young as, I think, 10 years of age. I don't think it says this here, but it can happen at a young age all the way to 80. But again, it's usually common when you get older. Another difference between Parkinson and this is that the essential tremor usually does not get worse. So once you get it, it's going to get a little bit worse, but it's not going to impede your survival. It doesn't get worse. You don't get the shuffling gait with it. Other problems which happen with Parkinson's, you usually do not get those with the essential tremor. So Parkinson's is a progressive disease. Once you're going to get it, it is going to get worse. It's going to get worse with time and leave you debilitated. So if you have to pick one of those, you want to get the essential tremor. Let's look at the last one. So this is the treatment. So now treatment, no, not this one, the third one. Next time I'm going to do it that alphabetically. I'll be able to do it. I'll name them 1, 2, 3. So this is how you treat it in a nutshell. So what was the defect that we said? We said the defect was in not getting enough dopamine released by the nerve cells in the substantia nigra. So the classical treatment, or the most common one, is the levodopa. So what is levodopa? Well, levodopa is actually getting converted into dopamine. So the neurotransmitter which we're missing, once you give people levodopa, they're going to be able to convert that into dopamine. Well, there's two problems with it. One of the problems is it also wants to get converted into dopamine inside your blood. So as soon as you take the pill, stomach absorbs it, it's in your blood, it wants to get converted to dopamine right there in your blood. So then if it gets converted into dopamine, that dopamine cannot cross the blood-brain barrier and go work where it's supposed to work. So what they do is, that's why you hear this thing about levodopa and carbidopa. So the carbidopa now, what it does is, you combine that with the levodopa, so it prevents the levodopa to get converted into dopamine outside in the blood. So it allows it the levodopa to go inside the blood-brain barrier, cross it, and then it gets converted to dopamine. So that's why usually you use that combination of that drug, levodopa and carbidopa. So that's one way to deal with it. The other way to deal with the Parkinson's is to use medications which pretend they're like dopamine. So they're dopamine mimics. So they mimic dopamine. So they act like dopamine, but they're not dopamine. So those drugs, I think we've all heard of them. One of them would be the mirror packs, which is used for restless legs in people. So that's actually a Parkinson's medication. And the other one is Reequip. So I'm sure a lot of people take that for restless legs also. So Reequip and the mirror packs, they mimic dopamine. Some of the other medications which I don't really use, by the time I have to use these type of medication, usually we refer them to the neurologist. There's COMT inhibitors. And one of the drug, which I don't know if you've heard of it, is called Comtan. So Comtan is one of the medication. It also prevents the levodopa from being converted into other ingredients. So basically allows it to get into the brain. These medications, we usually don't use them too much. They're called Mo inhibitors. And what they do is the dopamine inside we call this area a synapse, which is the gap between the two neurons. They prevent this dopamine from getting disintegrated. So, but you know, these medications, they usually will have their own side effects because they will interact with the serotonin type of medications. You can get the serotonin syndrome. So the basic way to treat it is give people stuff which either looks like dopamine or give them stuff which gets converted into dopamine. So we can get out of this. There was one important slide, the right one. So this is, don't look at the topic, it says it's for treatment of Parkinson's disease psychosis. But if you look at this I thought was much more relevant to your setup. So in the Parkinson's disease, what you want to do is if somebody is getting confused all of a sudden, so you got to look at those 2-3 important things: UTIs, pneumonias, what's that word again? Impaction. Forget that. So it says stool accumulation, but impaction can actually cause people to get confused and act differently. And of course, you got to make sure they didn't fall. Because some of these people, they have poor gait, they will fall, get a subdural, and they may not even complain that they fell. So those are the things that you want to look out for in Parkinson's patients here at the facility. The other thing you want to do is, some of them, because they have urinary problems, they are taking anticholinergics, which is Ditropan, you know, what do you call it, Visicare, and then there's another one, Detrol, for the overactive bladders. And of course, some of them are put on anxiolytics too. So these medications can also precipitate behavioral changes for psychosis. And of course, if you have a neurologist on board, sometimes the Parkinson's medication themselves are causing some of the side effects, and they have to be adjusted. We can get out of this. Finally, people who cannot be controlled with anything, any medications, that first picture there, deep brain stimulation. So they carry a gadget, like a pacemaker, goes through the neck, outside of the skin, into the deep parts of the brain, and stimulates the nerve cells to produce more dopamine. So that's a well-known method of controlling Parkinson's disease. Usually used after everything else doesn't work. Yeah, and we've had some people with essential tremor too, who get this deep brain stimulation device, and it actually also works for essential tremor sometimes. Thank you. Yes.